Now we will attend a lecture with Professor Brian about clinical practice guidelines for surfactant replacement therapy.
Okay, so we'll do the similar thing, and we'll kind of roll through surfactant replacement therapy. And I understand you have some challenges with surfactant replacement, not necessarily with the technique, and so we probably won't talk too much about that, but maybe the availability of devices for surfactants and in which time you do use them or not. And so I'll share with you kind of the evidence that we pulled together, mainly through a clinical practice guideline that I authored now 3 years ago, and so it was quite eye-opening. So won't kind of go through this too much. Is that it's a pretty big issue, surfactant deficiency. I may have confused you yesterday, and I apologize. I was probably working on 2 hours of sleep when I talked about new BPD. But really, what I was meant to talk to you about is that the new BPD is in place of patients who develop BPD that have already received surfactant therapy, prenatal steroids, those types of things. And so I apologize if I confused you that I was coming up with a new disease and new treatment methods for that disease. But obviously it affects a lot of patients, particularly in the U.S., and you guys know your numbers better than I do. And obviously it occurs most frequently in preterm infants, about 15% of all low birth weight, which is considered 2.5 kilos, and more the preterm infant, the greater the risk. And the cause is about 30% of neonatal deaths and 70% of deaths among preterm infants. And I'm talking about surfactant deficiency. So this is obviously what we're trying to prevent a lot of times is this dynamic collapse of the airway because of the lack of surfactant. And this is what occurs is that you go from a nice round alveolus that's supposed to be open and maintain its patency, but it doesn't, and it collapses a lot of times. Some of the other things that you have seen is that obviously the normal lung itself has these nice round alveoli and very thin walls compared to the RDS model, in which they're very thick membranes or hollow membranes and even have debris within those alveolar sacs. It is the common treatment for respiratory distress syndrome of the newborn, and like I said, the hallmark of respiratory distress was surfactant deficiency in the beginning. Now that we actively treat it, we have other reasons for RDS. So why does this happen? Obviously, they're premature. There's insufficient pulmonary surfactant. The existing surfactant may be deactivated. This is some of the older kids in which we give surfactant replacement to. I'll talk a little bit more about that. The preterm infant has immature type 2 alveolar cells. And something I want to bring your attention to is that I found a little bit interesting is that now with prenatal steroids, a lot of the surfactant studies were done before prenatal steroids were common. And so if you think about it, it's not the same patients that we're dealing with now that got prenatal steroids. And so I wonder if the treatment regimens that were designed from those original studies really should be followed to the T today, because we haven't redone those studies, and they probably should be redone now that we have kids who actually have maybe a little bit more mature lungs or type 2 cells post that. Other things that we use it for, and you see it fairly common in the literature, is foreign substances is kind of hallmark it. So meconium, serum proteins, blood aspirations, those types of things that deactivate the surfactant that they do have. And so it's not that they're so premature that they can't produce surfactant. They actually produce surfactant, but these other agents, bacteria, those types of things, can also cause deactivation of that surfactant and make them look like they have RDS from a preterm infant. Meconium aspiration is one that I did some of the original KL4, so synthetic surfactant with meconium aspiration, in which we didn't find that to be that helpful in removing debris from the airway and creating reducing the ball valve types of effects that occur from meconium aspiration. And it was quite interesting because Mainly the studies had us lavage in the lung in patients who weren't that sick. And you can imagine you take a full-term kid who's not that sick, and I'll lavage them with a surfactant that doesn't carry oxygen. So it wasn't mixed in like fluorocarbons or anything like that that would actually carry oxygen. What do you think I'm likely to do? Create pulmonary hypertension because I made them hypoxic from instilling a large amount of volume into their lung. And so the study was stopped because it seemed to have more complications than it did good. That being said, in the more severe patients in which you're thinking about transferring them to an ECMO center or escalating on therapy, surfactant replacement may actually be helpful, not in a lavage dose, but a treatment dose, because a lavage dose is something like 8 mLs per kilo, whereas a treatment dose can be anywhere between 3 and 4 mLs per kilo, depending on what surfactant you're using. Pneumonia is another one that I think it's potentially beneficial for, and again, more in the severe types of pneumonia. And so something I thought you guys were going to ask me about adjuncts is inhaled antibiotics. That's another thing that's being more and more looked at, and it'll be interesting to see because IV antibiotics or systemic antibiotics have a hard time getting through that thick membrane, and so can you nebulize it? And it may be true that you can, but I don't have much experience. We certainly have experience with it in our CF calculation, and then antivirals with ribavirin have been used. So back to premature infants, kind of the history of surfactant, and we started out with synthetic surfactant, Exosurf, and Exosurf, believe it or not, was not a bad surfactant, and actually it still had pretty decent outcomes when it comes to it's probably better than nothing type concepts. And so if you do have it, and I know some developing countries have Exosurf, but they don't have any of the animal-derived surfactants. And so I would say if you still have surfactant deficiency that you want to treat with a surfactant, I would use Exosurf, and it's probably better than nothing. The natural appears to have the best response, improvement in oxygenation and compliance. And there's the 3 common ones that we have here, Infosurf, Surfactant, and Curasurf. And so how do we give is obviously typically, this has changed over the years too. We used to do 4 aliquots, head down, head up, those types of things. And I participated in some of those studies, and so it's, I look back and I can't believe that I put a preterm infant head down to give surfactant, but I did, and I was part of that group because that was the way you did it, and that was what we thought would be the best distribution of surfactant based on gravity. But it looks like we don't really need to do that, and most people are going to just 2 positions, left and right, and some people do prone, supine, left, right. I think all those are probably fine, but I think in the extreme premature infant, probably the less movement, the better. In other words, left, right is probably the best. If you have a full-term kid that you can position and they can handle it, maybe 4 is okay as well. Obviously, warming the surfactant is something that's important, and there are all types of interesting ways people have a warm surfactant, as you can imagine. And I also put or according to the manufacturer, because Lucinactin was a surfactant that is no longer available, but that was a synthetic surfactant that came on the market in the U.S. And I believe they're trying to sell it around here. I know they've got it in Saudi Arabia and some other places. But they just most recently, right before I came here, took it off the market from what I understand. And they're focusing on the aerosolized surfactant product and not the installation one, because that's where their surfactant holds up and shows the most benefit. Because it does not degrade when you nebulize it, unlike the animal-derived surfactants, which degrade when you nebulize it, or basically chop up the proteins if you think about nebulization in that way. And then obviously the dosage depending on the surfactant type. So when do we give it? And this is kind of all over the place. There's opinions about prophylaxis, and I grew up in a NICU that was a prophylaxis unit that actually provided some of the evidence that it was actually beneficial in the smaller kids. So that's my tendency, even though the literature is kind of all over the place when it comes to whether you should do prophylaxis or not. Is the risk worth the benefit type thing? Because you do have to intubate those kids. You do have to provide a when I first started, it was 30 weeks gestation or less, and it was 1,500 grams or less. Now it seems like the new recommendations are getting more towards 28 and 1,250. And I think practice is probably even less than that. In other words, if you're less than a kilo and you require intubation at the delivery room, they'll actually give it. That was the other thing, is that prophylaxis requires intervention in the delivery room. And so if you can't do it in the delivery room within kind of the first 10 to 15 minutes, the likelihood of it actually benefiting long term was less. So it dropped by basically each hour that you did prophylactic surfactant. So, and some people have the capability to intubate, make sure the airway is properly supported, give surfactant, and then take them to the neonatal ICU. Some places you don't have that capability. And so some places actually have a resuscitation room in the NICU that they basically take the patient to and do it. But the goal has been to do it as soon as possible if you're going to do prophylaxis surfactant. Obviously, rescue is typically after the patient has declared that they have RDS. And it sounds like that's the way you guys use it here, from what I understand. And I think that's appropriate as well. And typically after they have a chest x-ray or they require some types of form of mechanical ventilation, typically we would always give surfactant rescue if the mean air pressure is greater than 7 or the FiO2 is greater than 40%. We would also redose off of the same criteria. So if I gave surfactant, I weaned them down to 30% oxygen, I weaned their ventilator settings to a peak or mean air pressure less than 7, I would not redose them, but I would evaluate every 6 to 12 hours to see if those ventilator settings were up again. If they were up again, I'd redose them. And how many times do you redose? That's the other question a lot of times. Is it used to be that we redosed like crazy, and so we'd go up to 4 redosing, but most of the time, most people are stopping at 2. In other words, if you give a second dose, it helps. That's probably good enough. And so I did share with you some extreme cases in which up to 5 is appropriate in kids that have chronic lung disease and are failing kind of conventional therapies. And those are the kids that probably have what I call the deactivation of surfactant. So they're having problems maintaining their surfactant pool, and that's why they need constant redosing. And so whether they're septic or have other problems. Obviously, the complications are quite severe, as you can imagine. One of the worst nightmares that I had as a intubator and giving surfactant in the delivery room without a chest x-ray is making sure that I did not right main stem the patient. Because you can imagine that if you right main stem them and give them surfactant all to that one lung, you got one compliant lung and one non-compliant lung. And that's just asking for trouble because they're so difficult to manage. And so even though the surfactant does spread across to the other lung, over time damage has occurred. We have this kind of rule, and I don't know if it's the same rule here, is 1, 2, 3, 7, 8, 9. So 1 kilo 7 at the lip, 2 kilos 8 at the lip, 3 kilos 9 at the lip. And if you're 500 grams, then that's 6.5. If that makes sense. And so these are some kind of common rules that you don't have 500 grams. 700 grams, I heard that was kind of the limit. So if it's 700 grams, it's like 6.75 at the lip. And so, but it's something that we would shy on the side of being high versus low. In other words, I would rather, if I'm going to give surfactant, I would rather it be high and potentially risk them extubating than it being too low because you can cause problems and those types of things. Pneumothorax is another one. This is why I was encouraging volume ventilation, because I think it's really important in this patient population because certainly you can stand there and watch for the first 15 minutes to an hour their compliance change and make manipulations on the ventilator. And the majority of the compliance changes do occur within that first hour after surfactant, but it doesn't mean that it doesn't continue to improve hours later. Does that make sense? And so you can get into a lot of trouble in these patients if you allow your tidal volumes to increase too much. And then pulmonary bleed, pulmonary hemorrhage, those types of things, which is pretty rare, fortunately, but when it does happen, it's a pretty bad complication. Obstruction is another one that we've seen, particularly in our smaller kids. I mentioned that we were resuscitating really, really small kids, and one of the things is that the study for dosing was not done in that small of a patient population. Does that make sense? And so the average, I think, surfactant age or size was 800 grams, 900 grams to a kilo when the surfactant studies were first done in the 90s. Now, when you're resuscitating a 500 grammer, does that same dose actually work? A lot of times they have so much immature lungs that they fill up with surfactant. And some people are really having a hard time giving the full dose of surfactant in the delivery room or even to the patient within that first time period. And so it's something that we have to think a lot about, is that dosing appropriate? And some people will pause, give half the dose, pause, and then come back an hour later and give the rest of the dose. Or just not give the rest of it at all. Obviously, compliance is something that you have to monitor, so whether you use pressure-controlled ventilation or volume-controlled ventilation, you have to make sure that as compliance improves, you appropriately adjust your ventilator settings. The other thing is that if you lower pulmonary vascular resistance with a child that has an open PDA, you can cause problems as well, and that does occur, and so you have to be careful that you're not vasodilating them inappropriately or not being on the watch for that because that can happen. So kind of things to help you, or at least in my opinion to help you, is I like the inline devices, and I don't know if you have that option. I know we talked about like inline suction catheters and those types of things. And so other things that we'd like to review is ventilator settings, so making sure that your peak inspiratory pressure is appropriate, anywhere from, I guess the literature is now pointing more towards 3 to 5 mLs per kilo, and so 4 to 6, I'm a little bit old school. And typically that takes a peak inspiratory pressure of 18 to 24 or so, and that's just based on my experience. I know I get worried if I have to use more than 25 centimeters of water pressure that things aren't going well. And do I have a patient that has another disease, such as hypoplast or something like that? Short inspiratory times are important, maybe even down to 0.2, particularly when you get into the faster rates. Rates of 30 to 50 typically are pretty good. And we do tend to shy on the side of hypoventilation if we have to guess. In other words, hypoventilation we feel like is probably a little bit better than hyperventilation, but the swings are really bad too. So if you pick one, stick with it, and don't do the swings because that's definitely something that you don't want to do. And we tend to do permissive hypercapnia. I think permissive hypercapnia is something that we need to look further at as well. Is that acutely, I think it's fine. Chronically, I'm not so sure. I'm really worried about it in our BPD kids that we send out that are so buffered up that they have CO2s of 70s, those types of things when they leave the hospital, because is that really appropriate? Certainly for the short term to try to protect their lungs, I think it's probably appropriate, but long term, not so sure, and there's not a lot of evidence that says that that's actually okay or not. This is the Ballard system that we use. I don't know if you have a similar system. I know people have made systems similar to this that work just as well, and so it's basically this catheter that we put into the ET tube. Yes, like the closed suction system, the exception is it's got a lure lock on it, and so this is kind of the way we position the baby to start with, and so we have it in line. I'll show you kind of even a little video that we use to kind of demonstrate the surfactant. So we turn them on the side, we advance it, we give half the dose, and let it go in basically until we see the surfactant's gone out of their endotracheal tube. We then position them back to their back and wait a few minutes there. It's usually very few minutes if they're okay. If they're recovering, then we stay a little bit longer. But if they're okay, then we turn to their other side, insert again, making sure that we don't go past the distance of the tracheal tube because we don't want to right vein stem it and inject it there, and inject the other half and pull out, and then we're ready to go. And you see that we leave the patient on the ventilator the entire time. We used to manually ventilate because we thought our hand was more educated than the ventilator. I think there's lots of evidence that says that your hand is horrible. You can't change compliance. You can't understand the different things that the ventilator can see and do. And for consistency's sake, it's probably best to stay on the ventilator if at all possible. Some people take the flow sensor out of line, and I think that's probably appropriate because you're trying to protect it from getting surfactant in it. Because there's sometimes when the child will cough and surfactant will go up into the flow sensor, and then now you got a dirty flow sensor that you can't use, or you have to take time to clean it. But obviously, you have to. If you're doing that, you need to be in a pressure or control type mode of ventilation to do that. Some ventilators won't allow you to take the sensor out of line. It will alarm and those types of things, and so you have to leave it in. But that's when I usually hold the sensor to the highest point. And so hopefully the surfactant won't get to it and mess it up. So then, as far as the clinical practice guidelines, and I'll end kind of here, is that we had 6 recommendations. So the first recommendation was the administration of surfactant replacement was strongly recommended in the clinical settings where properly trained personnel and equipment for intubation and resuscitation was readily available. And so this means that there are some hospitals, even in the U.S., and even within my geographical area, that aren't properly trained to do this. And so we tell them, we'll come pick up the child and bring it back. Don't touch the baby kind of concepts at times. And I'm sure you guys have places like that as well. And so we definitely think that if you give surfactant, it's not for the untrained or folks that want to do that. Prophylactic surfactant administration is recommended for neonates with RDS. And this is a 1B recommendation, so B meaning not the highest level of evidence. So in other words, there's still room for debate. And if you say, I don't give prophylactic surfactant here, I couldn't argue with you from the evidence perspective. But it was our consensus that if you do have the capability to do it, that it actually is beneficial when it comes to long-term outcomes. Rescue or therapeutic administration of surfactant after the initiation of mechanical ventilation in infants is, with clinically confirmed RDS is strongly recommended. And you see that one's the highest level of evidence. So some people would argue that that should have been our first recommendation because it's 1A. And so that's one of the higher levels of evidence that we can actually come up to. Everybody's a critic, though, you know. But we thought it was first important that people have properly trained staff to be able to give surfactant replacement because that's quite important. I know multiple dose strategy is recommended over a single dose strategy. So again, I told you about the 2 versus 4. Most people, that's still multiple doses, and so we stick by that. That's probably better if they meet criteria for redosing. It's not that you have to give 2 doses. It's just if they meet the criteria, we recommend that you give at least a second dose from that perspective. And it seems like the natural surfactants are still the best. If you have synthetic surfactants, that doesn't mean that you shouldn't give those, but whatever you have in that. And then, unfortunately, there's not enough evidence about the aerosolized surfactant. I do think that that's kind of the holy grail that we would love to get to, especially because we're using so much more nasal CPAP and not intubating these kids, is that if we can actually provide aerosolized surfactant, because we know they're surfactant deficient. There's no ifs, ands, or buts about that a lot of times, is that if we can do that non-invasively, that seems to be the best. But unfortunately, there's not a lot of evidence for that right now. And that research is being done largely with the aerosolized surfactant by Discovery Labs that I mentioned before, because the nebulizer does not mess up the protein, basically, or the protein mimic in the surfactant in that group. And so that's all I have. Any questions? So, minimum. That's a good question. So typically 6 hours. And so, 6 hours is typically the minimum. We have gone as long as 12 before we start saying we shouldn't even redose at all. So if they go a couple days without the need of surfactant and then all of a sudden develop a need again, we'll consider it, but it's less likely than if they kind of fall into the protocol that at 6 hours their mean air pressure is greater than 7 and their F-I2 is greater than 40. Then we say, oh, let's give another dose. You can, yeah. Most people will start thinking like after 7 days or so that they should be starting to produce on their own, those types of things. And so, But if they have deactivation, so in other words, if they got septic or they had other problems and somebody's taking up their surfactant in their lungs, then you probably should redose them. So.
Is it a better policy to open the lung first and then administer surfactant on an open lung, or to give the surfactant immediately after that?
Yeah, I think there's both camps, and so there's one camp that says yes, absolutely, you should open the lung first. There's another camp that I kind of belong to, is to open the lung, to do a recruitment maneuver before surfactant is difficult, and you're going to have these areas of hyperinflation and damage and tearing. But I came up from a camp that we actually did like LMA surfactant at the peritoneum, and so delivered the head, give surfactant in the nasopharyngeal airway, and the first breath, hopefully being delivered by positive pressure, would have surfactant in it, because as the lung basically removes fluid and takes it out, it actually takes the surfactant with it, and so there's more even distribution of ventilation. And you see those studies all over, and I didn't mention that, but people are using LMAs, these artificial airways that, or nasopharyngeal surfactant, and then putting positive pressure. And so when you then deliver the rest of the baby, their first breath, they inhale basically surfactant. And so people are experimenting with those types of things. And so there are two camps. One that says yes, and I think Natalie's group, they're doing some lung recruitment stuff in the delivery room, because they're in the camp that you got to open the lung up before you can deliver surfactant. I just worry what you have to do to do that is pretty extreme, because we're finding out that you can use 50 centimeters of water pressure and still not really open the lung. But are you actually going to start tearing the airway at those pressures? And that's what concerns me, is because the amount of pressure it takes to open the lung without surfactant is pretty high. And they're showing sometimes no differences in outcomes. And so are you risking the lung for a similar outcome? But it'll be interesting to see how the data turns out.
Your method of giving it even before the first breath is rational, because the lung is wet and the fluid is opening the lung and it is equally open. Exactly. But after the first breath, immediately after the first breath, there is some sort of heterogeneous, yes. And applying surfactant at this time on an unhomogeneous lung, you may over-distend and already open the lung, right, and leave the closed one.
Yeah, that's absolutely true, and that's, like I said, that's kind of the camp that I just kind of grew up with one of my mentors, Dr. Catwinkle, who really believed in that concept, is that, the lung is open, but it's fluid filled. And then when you transition to extrauterine life, and they take their first breath, fluid goes out, and then also goes out through the pulmonary vasculature as well. And so he's like, while it's going out through the pulmonary vasculature, can it take surfactant with it on the way in? And so, but obviously it's it's very cumbersome, as you can imagine, trying to do it at the first breath of life. It's a circus, believe it or not, as you can imagine, to try to do that. And those poor mothers, a lot of times, with us trying to actually do that, has been difficult. So from a humanistic behavior concept, it's really hard to actually do at the first breath of life. What about C-sections? That was another thing we ran into. They don't get to squeeze as they come through, and so they're not, entering a sterile environment. A lot of our equipment, believe it or not, is not sterile. So ambu bags, masks, those types of things are not sterile. They're clean. And so we actually had to send them down to be sterilized so that we could enter the sterile field to be able to do this surfactant replacement. And so there's lots of things from an operational side of things that have to be done before that can be common practice. And so
the pressure in the first breath might reach normally or naturally as high as even maybe 60 or even more.
Yeah, 60s and 80s, negative 60s and 80s.
Yeah. So why should I be worried about giving him high pressure to open the lungs?
Yeah. No, it's absolutely true, and that's the argument for recruitment maneuvers is the same thing.
So it's on the same time.
Yeah. Yeah. So that's the concept. Is that so? What he was saying for you guys that probably couldn't hear him in the back is that it only takes a couple breaths to basically injure the lung, and so certainly the first breath of life is very negative, high pressures, negative 60. I've even read up to negative 80. And those types of things. But after they do that for a couple breaths, because by the time you actually move them just from the mother to a radiant warmer or where you're going to work on them, they're taking breaths. And so how do you know how much they're actually taking and how effective those are? And so, because we have really small neonates that are crying the whole way across, and I'm like, okay, you've taken your first breath of life, so now what do I do? And so certainly the ones that are born apneic, it's a little bit easier to deal with and make those assessments. But I'm a little bit cautious about just applying that much pressure when I hear them breathing and crying and those types of things coming across. So, if the pulmonary hemorrhage has stopped, and you're sure of that, which is almost impossible to be sure, then it makes sense because blood in the airways and in the alveolus and stuff like that can cause all types of problems with deactivating surfactant. Same thing, we first started using it with blood aspiration from the mother. So that we're having tremendous amounts of bleeding problems, the baby was aspirating the whole time. And it seems to be fairly effective for that. So I would imagine it would be just as effective for pulmonary hemorrhage if the bleeding stopped. The problem is that if you rough up that area that was bleeding because you changed the compliance of the units around it, or you open it up itself. In other words, it may have sealed off because it got atelectatic, or has a blood clot, or those types of things, or thrombus, then that you may stir it back up again. And so it's risky, I think, at best. But a lot of times in those situations, you're pressed to do something anyway because they're either so hypoxic and they're not responding to traditional therapy interventions.
Welcome to Ancient University and Lady Natalie, and I'm happy that you collect your cross. You look so handsome.
I did.
Yes.
A little more presentable today.
Yes. Over 50 years of neonatology, I have some concerns and worries about our practice as regards surfactant. I do believe it's certain now subjective rather than be objective, and I like objective medicine. For instance, you have mentioned that for the prevention, any baby less than 1500 or 1250, whatever, but sometimes you are confronted with babies with this maturity, the enhanced maturity, maybe kilo, maybe 1500 grams, but mature line. So I was dreaming that we can put objective criteria for the use of surfactant according to the weight and the excision age, whether this baby is average for excision age or small or large. It differs. Especially in multiple pregnancy, we have babies 1 kilo, 0.3, and his twin is 1.7, and both have good lung. So, and I do believe also that perhaps whatever the score for the study says for Down score, for instance, 6 or 7 in full-term baby different than 6 and 7 in preterm baby. So I got so worried if full-term baby was 7, but it's normal to find preterm baby with the Down score is 7. So I do believe that the weight is not enough to get.
No, I would agree, and that's why I think I see that number getting smaller and smaller, because the original studies, like I participated in the original prophylactic surfactant studies, and we had actually mortality benefits and BPD benefits from it. But again, those studies were done shortly after the introduction of prenatal steroids. But not 100% of those babies got prenatal steroids because it was the time frame that we were working in the mid-90s. And so it was something that we developed a number to treat. And this is where I think you're getting at, is that not everybody will require surfactant and those types of things. But and so you often have to over-treat patients to actually get some patients to actually get benefit of it. And I think that's the gray area that I think we all struggle with, because before I intubate someone who's spontaneously breathing, even crying, and you go, they look pretty good. Do I really want to put an intratracheal tube in and give them surfactant and expose them to a lot more risk from surfactant, despite maturity a lot of times? And so certainly SGA, which we're in the U.S., we're getting pretty good at understanding their birth weight versus their gestational age, and so that's why if they're SGA, then certainly we're going to think about treating their gestational age, not their weight. And so we wouldn't use the criteria of 1250 if they were 1100 and 32 weeks gestation, or 34 weeks gestation. We'd say, all right, they're 34 weeks, we're not going to do prophylactic surfactant. And so that's something that we have to weigh often before we even go into the delivery room, if we have the option to weigh that. Sometimes we don't have that information in patients, but there are a number of patients in some of these studies that you have to overtreat to get some of them to actually have benefit, and that's the risk, I think, and that's something that I know that I've felt uncomfortable at times seeing a very healthy baby that I've exposed to intubation, and I like the extubation now, which is a lot of help. In other words, I can give surfactant and extubate them to nasal CPAP or something like that, and get them off the ventilator as soon as possible.
Okay, the preferable concentration to begin with, is it 100 or 200? The concentration, not the ml, the concentration, the dose itself. Is it to start with the 200 or 100? This is number one in question. And number two, the switch of the baby from the right and left and so on. This is not recently recommended, I think, from the company itself. So if there any change, the switch here, yeah.
Yeah.
And the concentration.
Yeah. So a lot of times, so the question to your, our answer to your first question is up here, and so it's 100. It looks like, depending on the surfactant, because it depends on how much protein D they have, and those types of things. But it's anywhere from 100, 105 to 200, and so.
I think that the guideline is start with the 200. And then
Oh, I see, yeah. I'm not as familiar with CuraSurf, and I know that they've been advertising that, the lower dose. And I know that we actually just switched over to CuraSurf, actually just before I came here. And that's the thing that they sell clinicians in the U.S. is the lower volume. Because remember I told you that we're having...
That's for UNICEF. The lower volume of 4 ml I think that the 4 ml has 200 in the Curiserve and 8 ml in the Surfactant has the 200.
Yeah, yeah. So
what you propose?
So we do the 4 mLs per kilo for Surfactant, and Infosurf we do 3 mLs per kilo, and so it's starting doses. CureSurf, like I said, I'm not as familiar with.
Apparently, the 200 milligram of phospholipid has got better pharmacodynamic effect. From the pharmacodynamic effect is better with much longer half-life than the 100 milligrams. So many recognize the use of 200. And if you are going, and sometimes it is essentially 200 if you are going to use it in meconium aspiration. In meconium aspiration, due to the denaturation of the surfactant, you should give it at the higher dose. At the 200, not at the 100.
Yeah.
Okay, and in RPS?
RDS, you can give both. If you can afford, it would be better to give the 200 milligrams with the Curiserve. With the Curiserve, you cannot give it with the Surfactant because you will give 8 cc per kilo. With the Curiserve, it is an option you can have, and it shows a better pharmacodynamic effect. With longer half-life and high stability with the 200. The problem is the price.
Yeah, the positioning. So you'll see when they get FDA approved in the U.S., they do not change their recommendations despite how many years there's been. So some of this is newer evidence about using the higher 200, for example, and those types of things. But you won't see their manufacturer recommendations change because they would actually have to go back and study that. And produce the evidence for that. And so they'll allow clinicians to order whatever you want to. I will say that I think we shy on giving the 100 or so in multiple doses. More doses than giving a big dose less frequently. Does that make sense? And I don't know if that's just our conservative, but we tend to stick by these guidelines that I wrote 3 years ago and stay with the 100, 105, and then give it more frequently. But I know that CureSurf has been pushing the higher amount and lower volume and less frequency. So that's been their selling point a lot of times to our clinicians. And so far it's working because clinicians are liking the lower doses because we're seeing problems mainly in their really extremely premature kids, in which, remember, the dosing was not designed for it to begin with.
We have to end this session because we are very late. Beforehand on, this is the last one. Natalie?